All right. Whoops.
Yeah.
Hi, everybody. Can you hear me? You can hear me. I can. Yay! Thank you for coming. You're so adorable. We have an amazing program today. We only have an hour of this incredible person, so I'm going to talk fast and give you to him mostly. I think you all know Zeke Emanuel. I will introduce him in a minute, but let me just thank Nelson, who is here, Nelson Lim, always in the back. Thank you, Nelson, yay. He's our inspiration. Also John McDonald, who couldn't be here, but Lauren, Josh, and Eileen are all here, without whom we would not be, so thank you for all that you do. I also want to say Rohit says hello. Rohit Chopra, who spoke last, is a really astounding person, as you know. He fell in love with you, so look out, he may come back. He says hello. Anyway, what we're going to do, I'll introduce Zeke, and then I will ask him questions for about half an hour, and then you all get half an hour. So you can't leave if you don't have a lot of questions. So remember that. Let me introduce Zeke, who really probably doesn't need an introduction, but Zeke is Vice Provost of Global Initiatives here and Chair of the Department of Medical Ethics and Health Policy. For 2 years, from 2009 to 2011, he was at the White House as a special advisor for health policy to the head of the OMB, who was Peter Orszag. And interestingly, it was exactly the 2 years I was there, so we overlapped. I used to be in meetings with him, and I used to be terrified because he's a genius, as you know. Fortunately, it turns out he's a really nice guy, too, so now I'm not so terrified. Anyway, we happened to be there.
At least you didn't call me sweet.
Sweetie, dear. I call everyone dear, you know that. Anyway, since '97, Zeke had been chair of the Department of Bioethics at the Clinical Center of NIH. He has an MD from Harvard Medical School, a Ph.D. in political philosophy, so you are perfect for this class. Also from Harvard, was at Beth Israel Hospital, at Dana-Farber, where he joined the faculty, and a visiting professor at about 7 schools, if I count right. Written and edited 9 books, 200 scientific articles, a columnist for the New York Times, is a loser. And he was on Morning Joe today, this morning at 7:45, so I want to hear if Joe abused you. But Zeke, you're astounding. So I thought I'd start quickly, and I warned you about this, because I, anyway, would love to know more about our healthcare system. I know, for 5 minutes, you get 5 minutes. And I think it would be fantastic because, just as background, you know, what it kind of looks like, who pays for it, how we compare globally in terms of cost. So go.
Can't do it in 5 minutes. We do run a course, actually now an online course in the healthcare system that you can actually take for credit here, and that actually goes into in depth. I also do teach a course on this. So let's just outline a few things. First of all, the United States in 2015 spent $3.2 trillion on healthcare. That makes the United States healthcare system the 5th largest economy in the world. We spend more on healthcare in the United States than the British economy, than the French economy. Only the German, the Japanese, and the Chinese economy are larger, of course, than the US economy. So we spend a huge amount of money. About a third of that, about $1 trillion goes to hospitals. About 20%, $600–700 billion goes to doctors. So that's the big pot, as it were. The money comes not quite, but about 55% from private sources, basically employer-sponsored insurance. I work for Penn. Penn provides me, allows me to choose insurance. Penn pays, and I put pays in quotes because I actually pay for it, but Penn kicks in around 3/4 of the money. I kick in about 1/4 of the money for the insurance. Actually, that money just comes out of my salary. Instead of giving me salary, they're giving me health insurance. And about 45% of the payment comes from Medicare, Medicaid, VA, and other government sources. The Department of HHS, which runs Medicare and Medicaid, the budget of that department is as large as the economy of South Korea. Okay? The Secretary of HHS is more powerful than the President of South Korea. I mean, it's just one way of thinking about it. So no army, but plenty of money. So that's the sort of short When you think of healthcare and you're worried about healthcare costs, which I am every day, you got to think about prices. Prices in healthcare are high and they go up faster than almost any other part of the economy. And then you need to consider the volume. How much of things are we using? And overall estimates by McKinsey, the Institute of Medicine and others is that about $800 billion, a third, a quarter of what we spend is waste. It's unnecessary tests and treatments. It's inefficiently delivered tests and treatments that could be done in cheaper places. It's fraud. It's bad administration. So there's a lot of excess gunk in the system that could be gotten out. So my last point is when all during healthcare reform, people would say, oh, if you're going to control healthcare costs, you're going to have to ration care in America. And it's like, really? I mean, we've got all this waste. As a matter of fact, we spend way more than every other country. We don't have a board here, but when I teach this course, I show this graph, which on the x-axis, if you can imagine it, is how rich a country is per person, GDP per person. So the United States is somewhere in the range of $50,000 per person. And then the y-axis up here is how much you spend on healthcare per person. This 2015, the United States spends roughly, if you can believe it, take a deep breath, $10,000 on healthcare per person. $10,000. Okay? An astounding amount of money. Anyway, if you graph how rich a country is by how much it spends on healthcare, it's a pretty good line. I mean, really good line. I mean, like a line you haven't seen with every country in the world on that line. Anyone take statistics in this class? Like someone? Right? The R squared of that line is 0.89. Okay? Have you ever seen an R squared like that? No. Right? Unbelievably good. Okay? The United States is the only country in the world not on that line. We're like, 3 standard deviations above the line. So we could get down to that line without the need to ration. Many of the countries on that line don't ration. It's really just how you allocate the resources. So we spend a lot of money. A lot of it's waste. About half of what we spend comes from the government and half from private sources. So that's the quick thing. And remember, I keep saying the last point I'm going to make. The last point.
You're not even at 5 minutes, I think, maybe 4.
Medicare and Medicaid are now 51 years old. They were passed in 1965 and started in January 1st, 1966. Medicare is for elderly people, everyone 65 and above, roundabout. There are a few other people thrown into the pot. And it's a federal program. Federally paid for, federally administered. Medicaid is for poor people. It is federally paid for about 57% on average. States kick in the other, and it's administered at the state level, which is why it's much more haphazard, much less loved, much less well-run as compared to Medicare, which is universally loved. And I mean, it has its flaws, believe me, but it's in general a better system. So when you think of Medicare, it's for old people. Medicaid is for poor people. Okay.
Awesome. A+. Awesome. So that's great context. So let me jump to the Affordable Care Act, which everybody knows about and hopefully is covered by. So I know that you will...
Well, wait a second. How many of the people in this classroom are under age 26? How many of you get insurance through your parents and plan? So about half of those people. When I asked this question at Yale, the entire class, there's undergraduate class, the entire class, right, is under 26, and 90% of them got their health insurance through their parents' plan because of the Affordable Care Act.
Wow.
So that's just one sign of the benefits people have realized.
Well, and Trump's kids, right, we think? some of them, the young one. Anyway, we won't go there. So anyway, I think that you wrote quite a lot of the Affordable Care Act.
No,
you will deny
not true.
it. See, he denied it. Well, it's not, believe me. You wrote a bunch of it, or some of it. You had great input.
Lots of people worked on it.
Okay, right.
It has
But
a
you
lot
had-
of mothers and fathers.
Okay, but you had great input. So a couple things on that. What was that like to do? Were you, I mean, how difficult was it? And B, how involved was Obama? Like, maybe tell us an Obama story. And 3, what were your big wins and big losses in your view in that act?
So, you know, first, something that stretches out over a year, you know, goes through cycles of yes, we're getting it, no, we're not getting it, yes, this is going to be in, no, this isn't going to be in. And one of the important things to remember about legislation is it's not done till it's done. You know, something could look like everyone's aligned, we're going to get it, it's going to happen, blah, blah, blah. And things all the time fall apart in Washington. And simultaneously, on the flip side, it looks like something's not going to happen. And then suddenly, whoa, it's in there. And I'll give you one tidbit on that. So the president insisted that the Affordable Care Act, unlike Medicare Part D passed under Bush, the Affordable Care Act had to be paid for. In other words, there was no deficit financing of the Affordable Care Act. The notion that, propagated by some people falsely, that it adds hugely to the deficit is total BS, okay? It's not just a little BS, it's total BS, okay? The president insisted half the money come from cuts in existing programs and half the money be new revenue, all right? Cuts in existing programs are like reducing the amount of money paid to hospitals, reducing the amount of money on Medicare paid to insurance companies. And the other half was we had to raise new revenue on people. And so one of the things you do in the Office of Management and Budget is where can you raise revenue from? You create a long list of potential revenue raisers, and then people go and X them out for, you know, can't do this for political reasons, can't do this because it won't, you know, it'll hurt this industry, blah, blah, blah. So one of the revenue raisers we have is that people making above $250,000 have to pay an additional 2.9% in Medicare payments. So Medicare is paid for by 2.9% tax on your payroll tax on your income, and your, the employer also kicks in 2.9%. So if you make over $250,000, like some people at this university, you have to pay an additional 2.9%. That's to help pay for the Affordable Care Act. So we created a long list of revenue raisers, many of which some of us love. You know, let's jack that cigarette tax up. It's a good thing, good for health, good for revenue. Let's sugar-sweetened beverage tax. Let's put that on there. Botox tax. We had a Botox tax.
Oh,
we
Zeke.
did. We did. We had a tanning salon tax. You know, and like these are like X. You know, it's like no chance on the sugar-sweetened beverage, even though you can raise a whole lot of dough. I mean, Americans drink an amazing amount of Coca-Cola, I learned. So, you know, it's like we're just throwing these. I mean, you have every idea because you have to raise, you know, $500 billion over 10 years. So the tanning salon tax, you know, it's like not happening, throw it out. Suddenly it's in the bill. You know, it's like you have no idea how these things happen. We need revenue. Turns out there is one person who is really, really, really against tanning salon tax. Any idea?
Dana.
Who? I will just hint.
Oh, sorry.
She's a female.
Oh, a female.
Huh?
It's a female, wait.
A senator. Where's Susan Collins from? Come on, man. Who's that?
It's,
Yeah, Maine. No.
think about sun.
So it was a senator from Arkansas. Any idea why? Tanning salons, tanning beds are made in Arkansas. You got to always think of these things. So that's how Washington works. You know, it's like
Interesting.
she was dead set against it. We needed her vote, blah, 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 but it got snuck in at the last minute.
Wow.
So it depends what you ask. Your last question was, you know, what was in the bill that...
Oh, we asked about Obama, too. How involved was he?
Obama. On some things, very involved, like he, you know, have to get half from taxes, half from cuts. No more than $1 trillion can be spent on it. No deficit financing of it. There are some things he wanted that we just couldn't get for financial reasons. It would have driven it over $1 trillion. So I'll tell you one story. It's too bad I don't have I didn't bring slides because I got a nice picture from this story. in July of 2009, where the healthcare team is meeting, and this time we were meeting in the second floor of the West Wing, the office of the head of legislative affairs for the White House. And there are, 9 or 10 of us in the room, I don't remember. And in comes the president. This is like 3:30, 4 o'clock on a very, if any of you lived in Washington in July, hot, sweaty, ugly day. And I have to say, by the July of 2009, we were pretty tired. We'd been in 6 months working at this thing for 15, 16 hours a day. Kind of depressed because, this was one of the downs. We had spent a lot of time, most of you look like you're too young to remember, but a lot of the spring and the early summer was spent trying to negotiate with Republicans. What would you want in the bill to get it to be bipartisan? So we had things like the Gang of 8, 4 Democrats, 4 Republicans, the Gang of 4, 2 Democrats, Senator Max Baucus, who was chairman of the Finance Committee, spent a lot of time trying to get Republicans, tried to woo Grassley, woo Brasso, woo Olympia Snow to come over. Anyway, we were sitting up there, and we were about to head into the August recess. The Tea Party was forming. It was not a happy moment. And the president walks in to give us a pep talk. And he is like, we're going to get this done. And to be honest, he seemed like he was in a different planet from the rest of us. How can you be so optimistic? We keep getting beat up here. But he was very optimistic. Anyway, in that meeting, let me back up, so parenthetically, if you're a member of the economics profession or educated in health economics, there's a part of the way we finance healthcare that really, really annoys you because it is regressive, it drives up healthcare costs, and it costs the American taxpayer hundreds of billions of dollars. It's something called the tax exclusion. So in 1954, Congress, in its wisdom to expand private health insurance, said, when an employer contributes to your healthcare premium, that amount is not going to be taxed. You're not going to be taxed on it in income tax or in payroll tax. So when Penn, for example, and these are just rough numbers, pays $5,000 for my health insurance, and I pay another $2,000 or whatever it is, that $5,000 I don't pay tax on, either income or payroll tax. So someone like me in the 35% tax bracket, that's worth real money. That's several $1,000s not taxed. And when you spread that out over the whole country, it turns out to be the single biggest tax break by far in the United States.
Oh my God.
It's worth, a few years ago, it was worth $250 billion. It's probably worth closer to $300 billion now. $100 billion. The next highest tax cut, the home mortgage deduction, is about $70 billion. So it's 4 times, 3.5, 4 times the next highest tax, okay? Now, it has terrible effects. It's regressive. I make more money, right? I get more relief. What liberal Democrat wants that? Second, it drives inflation because $1 in health insurance is worth to me more than $1 in pay because the pay gets taxed and the health insurance doesn't. It's one of the reasons most economists think we actually have high healthcare inflation in the United States because people negotiate better and better health insurance packages. So if you're a health economist, one of the things you want to do is limit, if not get rid of, the tax exclusion. Pay attention. The next year is going to be filled with debate about the tax exclusion. The Republicans love to get rid of the tax exclusion, as do all health economists. The American public does not. But we thought we should at least limit the tax exclusion. We being the people on the economics team. I was at OMB. I was part of the economics team. President had run against John McCain and spent $150 million in ads attacking McCain for proposing to get rid of the tax exclusion. And we were saying, Mr. President, you should change your position. Now, if there's one thing that's true about Barack Obama, and I'll tell you this flat out despite a lot of the slander against him, he actually was very serious about keeping his word to the public. He did not like to go back on campaign promises. Almost every time we met in, for example, the Roosevelt Room or to discuss it, he would ask, well, what did we say in the campaign? Is this consonant with what we said in the campaign? Well, this was a case where we were trying to get him to move off the campaign pledge. And I happened to be sitting immediately to his left in this hot July 2009 meeting. He was giving us pleasantries, giving us the pep talk, blah, blah, blah. And I said, I was bold enough to say, Mr. President, you know, we've been debating the tax exclusion. And I know that you're well versed in it, but you know, I think you think of it as a way to raise revenue, right? If you cap the tax exclusion, there are tens, if not hundreds of billions of dollars there, really easy to get to pay for your health care bill. So but he kept thinking of the tax exclusion regarding raising money, using it to raise money to pay for the Affordable Care Act. And I said, you know, but that's not its real purpose. The real purpose is you as president have a lot of levers to control health care costs through Medicare and Medicaid. You have very few levers to control health care costs in the private sector. One of the only levers you have to control health care costs in the private sector is the tax exclusion. And if you limit the tax exclusion, you will be able to get health care inflation down. And it was quite clear he hadn't heard that argument before, or if people had made the argument to him, it hadn't registered that this was one of his only really effective ways to get health care inflation down. And I said to him, I said, this isn't surgical, it's not a scalpel, it is a cleaver, it's very blunt, and it does go against what you said, but it will be very effective. That was Friday. On the Monday or the Tuesday, the next Monday or Tuesday, we had 3 economists come in and sort of validate what we had said in that meeting. And the tax exclusion got included in the Affordable Care Act. It's called the Cadillac tax. It limits the amount of the tax exclusion. It's a very convoluted way. It doesn't limit the amount that you can get. It makes your employer pay a penalty if he or she gives you insurance above the cap. It's a sort of scratch your left ear with your right arm kind of thing. But really, really important because no employer wants to pay that penalty. Congress last year, 2016, voted, so it was supposed to go into effect in 2018, the last part of the Affordable Care Act to actually be implemented, and they postponed implementation to 2020. Unfortunately, my bet is the Republicans will do one of two things. They'll make it more restrictive, or they'll cancel the Cadillac tax altogether. It's like crazy opposite approaches, contradictory approaches, but that's what they're likely to do. In any case, that was one of my Obama stories.
Awesome, awesome. Okay, so more fast forwarding. So now we have Tom Price, who's been nominated to head HHS. Yeah. I assume he'll be confirmed.
Well, don't assume it.
Oh, good. Sorry, that was partisan.
I mean, first of all, you know, Chuck Schumer laid down a pretty strong statement yesterday about the fact that the nomination of Price, who's been against Medicare and against Social Security and other things, is, you know, a war on seniors, and he may turn out to be the place they really want to draw a line in the sand. I don't know. I'm saying, don't assume just because he's nominated. I might repeat the name Tom Daschle to you. You know, he was nominated for HHS, and there's a minor problem in his tax return. He ended up not happening. I have no idea what Mr. Price's tax returns look like. They will get careful scrutiny. Lots of other stuff will get careful scrutiny. I can also tell you that the AMA rushed out with an endorsement and has gotten a lot of negative response from a lot of doctors about the rapid endorsement of Tom Price. For one thing, look, Sorry, I'm jumping ahead. I didn't even
No,
let
I
you
love
finish
it.
with the
This
question.
is great.
Tom Price is not simply someone who wants to repeal Obamacare. I mean, that's sort of, if you're a card-carrying Republican, you want to repeal Obamacare. Tom Price is someone who wants to repeal Medicare, okay? Go back 50 years. And that's much more controversial, much, much more controversial. He would like to just simply privatize it and basically get rid of Medicare as we know it. It's very, even within his own party, that position is highly, highly controversial. So I don't think it's a foregone conclusion. You guys we're in Fels here, right?
Yes.
Right? It's a Institute of
accurate.
Government. One of the things you need to think about, all right, is the Republicans, while they usually looked a lot more unified than the Democrats, are hardly unified, okay? Just think about the mechanics now. You should be spending a lot of time thinking about, all right, what is the personality of the Trump Republican, what's all this about? First of all, Trump's not a traditional Republican, right? Steve Bannon, his counsel, is no lover of the Republican Party, right? He may be right, but he's no lover of the Republican Party. That's first. Second, who does, is there any reason to think Trump knew Price, liked Price, had any idea about Price? No, right? Who's Price then? Where's he come from? Who appointed him? Pence, right? Pence is running the transition. So Price is a Pence man, not a Trump man. And don't think that Pence men and Trump men are the same, right? Remember the acceptance or the victory speech that Donald Trump gave on the election night? What was the most interesting thing about that speech? He almost totally forgot he had a vice president and who that guy was, right? When did he acknowledge Pence? He had to be reminded at the very end. Oh yeah, Pence, that guy.
Well,
Right?
I only met him because his plane got delayed, right? In Indiana.
The Treasury Secretary, the Secretary of State, Wilbur Ross at Commerce, those are Trump people. He's going to, Mattis, those are Trump people. He's appointing those. Those are people who, he knows he wants, okay? Price isn't that guy. Now, who knows what that means for healthcare policy, whether Trump is going to even listen to Price. But second thing you need to think about is, what is the biggest antagonism in Washington today? Two people who hate each other more than anything else. Trump and Ryan, right? Ryan would not endorse him. Trump is not that kind of guy, right? Just because, they're Republicans doesn't mean they're going to get in bed and make nice together. Or whatever else you do. Ain't going to happen, okay? So these fissures are going to come up. And they're going to come up early and often. And how that plays out in healthcare, Ryan's got a plan. It's not clear that's Trump's plan. Price has got a plan. Not clear it's Trump's plan. We don't know what Trump's plan is, but he said many contradictory things, right? I like Medicare, right? It's not what Price likes, right? So
Interesting.
I don't want anyone to be uninsured. The Ryan plan uninsures many, many millions of people. We'll see. So I actually think there's a lot of going to be a lot more division there, and that is going to be important because the idea that we're going to rush through things, not clear, and I'm not 100% clear that a repeal without a replacement is something the president-elect is going to be very supportive of. Because you get a repeal without a replacement, you get millions of uninsured people. They're not going to blame it on, Ryan. It's going to be blamed on the president. And the president doesn't want to have that on his record. It'll undermine his entire presidency. So we got to, things are more complicated than they always look.
Okay, so last question from me, then I'm turning to you guys. So what do you think will happen? I mean, if you had to look, I know you have to though, you have to answer. In 4 years, what do you think it'll look like? How do we maneuver this guy, Trump? How do we maneuver Pence and Ryan so that, in a perfect world, what would we see in 4 years?
In a perfect world. Well, that's a different question
Well, no.
than how do we get.
I mean, realistically,
So
with these guys.
I'm actually, so I think there's a very high likelihood that there will be a lot of that the last 2 years of this administration will be spent with a lot of congressional investigations into corruption. One of the remarkable things, most remarkable things about the Obama administration, you have not heard of a single person, not even one person, with the hand in the till.
Yeah, great.
Right? It's pretty remarkable. There's almost no administration that's gone without any person, right, with any sniff, hint, whiff of corruption. It is pretty remarkable, okay? This administration, the incoming administration, has a different view of the relationship between government and private gain, all right? And I believe, you know, we're going to hear on December 15th what his plan is. Whatever his plan is, I think the sort of general idea that it's okay to benefit is something that is going to be in the air in Washington. And I think you are going to see a number of problems. Now, who will investigate those problems? The Republicans will. Again, because Trump isn't their man. And I believe that you are going to see some of those issues. I think my bet is also at the end of 4 years, he's not interested in re-election. I'm not even sure he's interested. I think in his ideal world, he'd be president for a day. Doesn't work that way, unfortunately, in America. It's not the parliamentary system. You know, so I'm not sure at 74 he's going to be so keen to spend more. He got what he wanted. I won. Bloomberg never won. You know, no one else in New York won. That's all I wanted. And you know, it's a hard job. No one goes into that job and comes out looking younger than when they started. Anyway, I'm not sure, and I am probably more optimistic than most. I actually think a lot of the things they think they're going to get done, they're just going to ram through. Internal divisions turn out to be really important. So let me just end this part of it. When the Democrats came into 2009, we were in the midst of the second worst recession, you know, depression in American history. You know, worse than 1907, worse than 1893. You know, bad stuff was happening out there. Hundreds of thousands of people were losing their job every month, right? My brother, as chief of staff, was like, we're going to have a recovery bill and we're going to pass it on day one. It's a great aspiration. Did not happen. Despite the fact that the Democrats controlled the House, had a 60-vote, bulletproof, filibuster-proof Senate, right? Didn't happen. Turns out passing things is a lot harder than it looks, right? And internal divisions within a party. There are many divisions within the Democratic Party that prevented a big bill. And almost every credible economist thought we needed to go over $1 trillion in a recovery bill, and we ended up with $787 billion, okay? And a lot of it was skewed to tax cuts as opposed to spending, which would have been no doubt better on the actual recovery part of it. So the idea that, you know, day one we're repealing the ACA, not so fast. We're going to have this big corporate tax cut. I do think they'll get a corporate tax, but it won't look anything like what they go into it with. The negotiations are very complex. So I think the number of achievements they get, you know, none of these guys are Lyndon Johnson, who know how to do this and can get it done in 6 months. Not perfect, but get it done. So I actually think we're going to get they're going to achieve much less. We're probably going to get much less on the repeal side of things. So I'm an optimist. And I think also the president is going to learn, well, you know, maybe some of this view that I had at some point in the last year of the 27 views on some subject, I like this one now. Mm-hmm. You know,
well, he's done that already a lot, so yeah.
I think uncertainty is very high in the system. Mm-hmm. To some degree, that might work to its advantage for the short term. For the long term, it's not going to be it's going to be an issue. We still don't know whether his son-in-law is going to be in the White House, which I think would probably be a good thing, all things considered. So,
Good. Very helpful and valuable. All right, you guys turn. Great. Let's start up here.
Yeah, so you kind of had mentioned, I guess, like a compromise with the Affordable Care Act and bipartisanship. And I guess my question is, at what point does a compromise become more or less like a failure for that individual senator's perspective or constituency?
It's a really good question. So if you were a Republican, okay, what do you need to say you repealed the ACA, right? What is the kind of indicator I've repealed the ACA? So it seems to me you've got to do two things, right? You've got to get rid of the mandate, and you have to get rid of the exchanges, the state exchanges, okay? That's what repeal looks like for a Republican, okay? If you're a Democrat, what could you well, I could get rid of the mandate and I could get rid of the exchanges if, right, I get something to replace the exchanges. Maybe I have a national insurance pool, rather than state-based, we don't call it an exchange, we call it a pool, something like that. Still with income leak subsidies to people to help buy insurance, no mandate, but some other ways of insuring or requiring people to buy insurance. Continuous coverage, you can only come in every 2 years, you can't do anything in between so that people can't game the system, which they seem to be doing, I don't know how much, but so I think there's probably a compromise there that you can outline. If we're going to block grant Medicaid back to the states, and I do think that on the Republican side there's consensus for doing that, what are the requirements you put in terms of financing, minimum coverage requirements and things? So the Republicans will be happy to get block granting. But, if you look at the block granting proposal by Ryan, and again, here's where the details really matter. He wants to change the inflation rate that you increase that block grant to CPI, general inflation. Well, healthcare's gone up above general inflation not quite, but almost every year for 50 years. That ain't going to work, right? That's simply a cost shift from the federal government back to the states. So if you're a Democrat, okay, we will block grant on a per capita basis to states. It has to be per capita, not just, and it has to increase it something above CPI, call it GDP plus 1 or something like that.
So I guess follow up, you also had mentioned there was like the example of the Penn tax that was like, it was in there and then it was taken out, and then you said it was kind of snuck back in there. My question is, how do you...
I didn't say snuck. I think you used that word, sir.
I implied, okay. But I guess how do you get that kind of concession to have it taken out, but then get it back in there and still have to go through with, I guess, is it just a matter of having somebody else come on board, but that Arkansas senator is...
No, she voted for it in the end. Yeah, I mean, one of the things about big bills is you try to, I didn't say this, but you try to persuade with goodies that are in the bill. That's usually called a bribe, but persuade with goodies in the bill for people, things that they can identify with in that bill that are good for them. I mean, that's how legislation gets passed in this country. And I'm not that person, but many people think that removing the earmarks, which Congress did, actually inhibited the possibility of passing legislation, right? One way of greasing the wheels is, here's a goodie for you, here's a goodie for you. Now, it can be abused. There are ways of restricting it other than totally eliminating it. But let's face it, it also does help. And, putting things in or taking things out that are favorable to people, kind of important. So a story of, many of you have probably seen Lincoln, the movie that had that thing about, making someone a postmaster, doing a lot of deals to get votes. Lyndon Johnson wanted to get the Civil Rights Bill passed in '65. And I forget who the Southern senator who was holding it up in committee. And Johnson, as a genius of this, knew that this guy's family had a big farm and got a lot of ag subsidies from the federal government for the farm. And he's like, you know, Senator, we're going to remove those ag subsidies unless this bill gets out of committee. You know, it's like people like, you know, not many people could do it the way Johnson could do it, but, you know, those are the kind of things you can do with, you know, earmarks and other That's democracy. You know, we may not like it. It may not be pretty, right? It may not be our view of democracy, but that's how legislation gets passed.
Well, it's human beings. I mean, we give them lunch, they come today. So, you know. How about there was somebody, yeah, in the back. That's great, yep. There's a mic behind you.
My question relates to the gunk and the waste that you talked about at the beginning of your remarks. We still think about the delivery of healthcare as necessarily being tied to a hospital system, right? So if I'm sick as a patient, then I go to an ER, and then I have access to a whole suite of technological and resource capabilities that that hospital has to offer. Do we need to rethink that paradigm of the delivery of healthcare? For example, thinking about practitioners as being more mobile, or relying on technology advances to, you know, have the interface between patient and doctors? And if so, what can we do from the policy perspective to try to encourage that?
Yeah. So, if you look forward into my crystal ball as to what the healthcare system is going to evolve to, one of the things I argue that is almost inevitable is what I call deinstitutionalization, moving healthcare out of the four walls, especially of the hospital, but even of the physician's office. A lot of things that we do in the hospital do not need to be done in the hospital. Just give you an example. Hip and knee surgery, right? Get a hip replacement, get a knee replacement. Right? You don't have to do it in the hospital anymore. You can do it in an ambulatory surgery center, right? Huge cost savings, just that move alone. When I was growing up, did you mention that I'm an oncologist? So I'm an oncologist.
No.
You did mention I worked at the Dana-Farber.
Dana-Farber, cool.
So I'm an oncologist, and when I was growing up in cancer care, a lot of the chemotherapy we gave, we admitted people overnight in the hospital. That almost never happens anymore. Now, part of that's better supportive care, blah, blah, blah. But, you know, moving the delivery of care out of the four walls of the hospital, definitely happening. I'll give you another example. Bundled payments, that is, giving a defined amount of money for everything involved in a procedure, like a hip replacement, the surgeon's fee, the radiological workup, the hospital, the implant itself, the surgical suite, the rehabilitation. That incentivizes rethinking how you're delivering that care. And one of the things when you do it that way that happens almost immediately, rehabilitation patterns of care change. The idea of sending someone to a rehab hospital goes away. Everybody goes home, most everyone goes home and gets the rehab in their house. Again, turns out to save probably $1,000 to $2,000 per patient. Increases your home care costs, but decreases your rehab facility costs even more. So it's net cost savings. So that kind of stuff is going to happen, especially at the hospital level, especially at the skilled nursing facility level, the rehab hospital level. Some of it will even happen at the physician office level. So I think that is definitely a trend, and to encourage that trend it's really all about paying doctors and hospitals to care for patients in a very, very different manner.
Fantastic. Yeah, here on the end.
Given the role of Trump's pick to head CMS in Indiana and Kentucky, I'm wondering what insights you can glean from healthcare reform's implementation in those two states with her work alongside Governors Pence and Bevin, and what your assessment is of her nomination and what she would do in the job.
I don't know enough about her. She clearly negotiated a very strong deal on Medicaid to get waivers. It's the most extreme waiver they granted for an expansion state that included working and paying and things like that. It didn't fundamentally change what the program's supposed to do. Now, she was negotiating against Democrats or people in Medicare who really, Medicaid, who really think it has some important safety net aspects to them, want to keep it. And that bureaucracy is not going away. They still have that inkling. So I think, again, probably she'll be more likely to give waivers to states. I don't think she's going to be able to fundamentally change the character of the program. That would be my bet.
Great, in the back there, with the hat, yep.
Hi, thanks for being here. So I actually got to take Zeke's healthcare policy and reform class. You should definitely all take it. I've learned the most. It was the best class I've ever taken at Penn.
Wow.
So I'm not just
$20 after this class.
Yeah, really, funny.
Yeah,
Funny.
I've been racking it up everywhere I go. Anyways, I know that in class you had a graph there, and we were talking about kind of like the high cost of healthcare, and there's a lot of different reasons for that, or that we assume. So one of them might be tort reform. One of them, there's a lot of different things that go into it. But I remember one thing that stuck out to me the most was technology. And so I think, could you speak to that in terms of like how our technology has increased the cost of care, and whether or not you think we should be really utilizing the technology in the way that we do, or if we should just kind of go back to our like previous ways of like conducting surgeries? Thanks.
Great. So if you look at where healthcare costs increase from year to year, about half the increase is from price increases that are above inflation. So healthcare costs that are going up much faster than the underlying inflation in the economy. And then about half is utilization that and in both those cases, there's an element of a drive from technology. So, if you look at, say, the increase in drug spending over the last few years, in 2014, it went up almost 15%, drug spending, and in 2015, it went up 9%. Not almost all of that is accounted for by two drugs, Sovaldi and Harvoni, right? Those are the two hepatitis C drugs that came onto the market. Brand new technology, really great technology, super expensive. Okay? So, and that's just one example, just in that case, one drug. Almost all the price increases in terms of the pharmaceutical industry are new drugs. Where was I? Oh, I know where I was. I was waiting in the green room to go on to the Morning Joe show, and the advertising, and I don't own a TV, so I never see these ads, so I don't know what's happening in the world in terms of advertising. Anyway, I was sitting there, and big ad for a cancer drug, and it struck me because it's a lung cancer drug, and the ad kept saying, proven to lengthen your life or something like that. It's Optivo from Bristol Myers Squibb. And it's like big stuff, and it made it sound like fantastic. You're going to live longer with this drug. This drug's $150,000, and it adds less than 4 months of life to people with lung cancer, right? You would never know it from that ad.
Wow.
All right, $150,000, 4 months. It's like, that's the kind of advance in technology that doesn't save a nickel. And certainly, you'd have to ask deep in your soul of whether it's worth it. Most people who are going to get that drug would not pay if they had to pay out of pocket, right? The only way they're able to afford that drug is because the rest of us are paying for that drug. So it's that kind of technology advances. It's also the abuse of technology, and I'll give you another example. Again, I'm an oncologist. I see everything through the eyes of oncologists. But researcher out in Seattle did the following study, looked at something called PET CT scans, positron emission tomography combined with CT. It's a way of identifying small microscopic residua of cancer. He looked at women with very early stage breast cancer and how many of them got a PET CT. Now, the advantage of looking at early stage women with breast cancer and PET CT is none of them should be getting it. 0. It's against every guideline that is out there. And then he went around to all the clinics and hospitals in the Seattle area and looked. And at some, 8 out of 10 women with this early stage breast cancer, almost never metastatic, were getting these PET CT scans. And at the lowest, it was 1 out of 10. Right? This is a scan, $5,000, and no woman should be getting it. Right? So it's not just the technology, it's also the abuse of the technology, the using it for where it's not proven and where it has no benefit. I recently went to a multi-specialty medical group in Westchester County, New York, called WestMed, which is it's transformed how it delivers care, really delivers super high quality at a very reasonable cost. And we were going through one of their facilities, and guy who head CEO says, and here's my PET CT scanner. And it's like, what the hell do you have a PET CT scanner? And he says, and I spent $2 million on it. Not only that, it was $600,000 just for the lead in the room. And I'm like, this is nuts. What? He says, and I never want anyone to use it.
Oh, God. Wow.
I said, what? And then I said, and then the penny dropped, and I said, aha, now I get it. If you send your patient to a neighboring hospital to get a PET CT in the cases where they need it, first of all, they'll do more than you probably will want, and they'll charge you $5,000. And if you do it here, he said, 7 or 8 will get done over the course of a week. We'll have very low utilization because I make it difficult to get to, and the cost is $2,000. So it's a very different way of understanding. And he says, yeah, $2 million. I'm not capital constrained. I can spend the money, and I'll make the money over 5 years by not spending $5,000 for scans out there, but only spending $2,000. So a lot of it is which technology you use, when you use it, and how you actually deploy it. We all want technologies that are going to make a big difference, not a small difference like 4 months of life, but we want to use them in the proper way and not abuse them and use them unnecessarily, which just drives up costs for no health or clinical benefits.
Mm-hmm. Interesting. Complicated. Yes?
So I was actually going to bring up FC drug.
Microphone.
Hold on.
Yeah.
I was actually going to bring up, I forget what it's, Sobaldi or something nice like that. But it costs something like $84,000 for the 12-week treatment.
That's the list price, yes.
But not everybody pays that, like you say. So, but what do you think about this idea, I don't know if others have it, of the government just outright purchasing a patent for a drug like that we know, or a drug, say, for malaria or something that kills a lot of people? The government just purchases it and then makes it a generic drug so that you avoid the research constraints, you avoid making pharmaceutical companies mad, and then you make it basically available for treatment for the masses.
Lot of money, not clear the drug companies will sell, right? I mean, so then the question between you and Gilead, who's the maker of Sovaldi, is, all right, what's the price? So Gilead paid about, the company that had developed Sovaldi spent about $1 billion, call it $2 billion, in developing it. Gilead spent $11 million buying it and made in the first 2 years like $15, $16 billion, 50% profit margin, something like that. So the question is, what price are you going to buy it at? That's the first problem. The second problem is you now spend a lot of money for Sovaldi, okay? And then Gilead comes up with Harvoni, which is even better. You're going to spend another $15 billion on that? And then we're going to come up with something else, even before the patent's expired. And I'll give you a real concrete example like that. So Merck developed the HPV vaccine, right? Herpes, human papillomavirus. At some point, the fatigue will kick in. Human papillomavirus, and the first vaccine was targeted against 4 of the virus types, right? And then they developed a new version that was against 9. What are you going to keep, buying up from them? So I think it creates a problem. It's not a perfect solution. Plus, it's a lot of dough. We're just talking about the first drug. Each year, the FDA approves, call it 40 drugs. I don't think it's, government isn't going to do that, okay?
What if the government views eminent domain as a threat?
It ain't going to happen.
Because it's controversial?
Yeah, just not going to happen. And you'd kill the golden goose.
Need research?
Yeah. I mean, that would kill the golden goose. The real problem is setting the price, if you ask me. The issue is not. So let's talk about drugs for a second. In the drug industry, right, the United States government gives drug companies a monopoly, right? It's called a patent, and it's called FDA marketing exclusivity, right? And basically we say, you've got this thing, no one else can come in unless they make a similar but not the same drug. You've got a monopoly to the market. Typically, after the research and time, that monopoly is about 10, 12 years. You've got a monopoly. Now, go to any basic textbook in economics, open up the chapter to monopolies, and what do you see, right? Monopolists, the people who control a monopoly, will raise the price until the world screams, right? You get rents, you get excess pricing power. Now, every country that gives drug companies a monopoly, right, has put in a regime of regulating the prices they can charge. They do it in different ways. Switzerland has a maximum price. Britain and Australia have different ways, and they calculate a cost-effective limit that a drug has to have. But everyone regulates a price. We are the only country, developed country, that gives a monopoly and doesn't regulate the price. Eventually, we will get around to regulating the price. I am very sure of that. When, I can't tell you. That we will do it, I can tell you. All right? That is the issue. And for the drug companies, say, they have all sorts of excuses. Every excuse under the book, right? First, we need that high cost for research. Turns out, less than 20% of the revenue goes to research. Almost all of them but one have more marketing costs than research costs. Second, the fact is they're making on average across the industry, 15% profit. They're the most profitable industry of all industries, more profitable than financials, okay? Lots of other industries, cars, oil and gas, right? They're perfectly fine with profit margins under 10%, right? They don't need to be incentivized at 15 or 20% profit to actually develop. And it's not like Pfizer, you tell them, all right, we're going to regulate the price and price is going to come down and your profit margin will come down to say 10 or 12%, 10 or 8%. They're going to say, we're getting out of the pharmaceutical business and we're going into, home baking. Just not happening, right? They're in the pharmaceutical business. Now, it'll change what they do and what they invest in, but, that's responding to the marketplace.
Okay, 2 more quick questions, if that's okay. You okay on time? 2 more? 1 more.
I've got a meeting
All right.
back at College Hall.
1 more question. Yes, in the front.
Thanks, Dr. Emmanuel. Republicans have been criticized, and probably reasonably so, for a lack of detail in their repeal and replace proposals. Representative Price probably has the most detailed plan out there. It's been out there since '09. It's been refined. Can you name a couple of things you like about Representative Price's proposal?
I'm not sure. And first of all, in part, I don't think there's enough detail in it. Yes, it's been out there. It has been legislation, but it's not a full enough detail. Look, I won't comment about him, but one of the big divides is almost all the Republicans say we're going to subsidize people to buy insurance in the private market who don't get employer-sponsored insurance. You have to do that because it's very expensive. A big question and part of the detail you need to ask are two. One is, how much are you going to subsidize, and how does that subsidy match up with the cost of actually buying a plan? A large part of the proposals are underfinanced in that regard, you know, and Representative Price is one of those. He gives, say, for a 50-year-old, $3,000. You can't buy a health insurance plan for $3,000. Minimum is $7,000, and that means you're spending $4,000 out of pocket. That's a lot more than the Affordable Care Act for a 50-year-old. Second, you need to ask, are those subsidies income-linked or are they flat subsidies? Now, Republicans have a tendency to like flat subsidies, which benefit the rich rather than the poor. There are some plans out there that do have subsidies that increase with income. Hatchet has, for example, an income-linked subsidy. I would also remind you, Republicans in the room, that Richard Nixon was another person who had a subsidy plan way back when, and his was also income-linked to buy insurance. So those are two things you need to critically look at. Is it income-linked, and is it enough to actually buy a insurance plan? On neither of those cases is Price in the right corner, in my opinion. Okay, those are two things I don't like about his plan. Second, he backs up his continuous coverage plan with, we're going to have high-risk pools in the states. Okay, you can go that way. It's not a very efficient way to go, but you can go that way. Now, whereas Representative Ryan, his proposal has $25 billion for high-risk pools, estimated to cover around 3 million people, 1% of the American population. Representative Price has between 1 and 3 billion, depending on the year you look at his proposal. Maximum 3 billion, 1/8 of what Representative Ryan says you need. That's going to leave a whole lot of people who have pre-existing conditions without insurance. He's not very protective of those people who he claims ought to be able to get insurance. Those elements are things I don't like about his plan, and I think it's made in a way that is not very likely to get a lot of coverage. I think if you unpack his plan, and by the way, it's never been scored by the CBO for how many people will lose insurance and how much it'll, in the end, cost and whether it'll raise insurance rates. My suspicion is he's going to end up with something between 12 and 20 million people without coverage in his plan. And that's not a very good place to be.
Politically.
So maybe, humanly,
Yeah.
maybe in the give and take, he'll negotiate. But let's face it, Representative Price, no matter what you think, even on the Republican spectrum, is pretty far to the right. And so, I think he would have a hard time, my suspicion is, of getting a lot of support from the dwindling number of moderate Republicans. Okay, thank you very much.
Thank you. Thank you. Thank you all. You're fabulous. We are lucky to have you on the planet and at Penn. Thank you, Zeke.